I am Gunawardhana LADHP. I am the demonstrator from the Department of Surgery, Faculty of Medicine, University of Kerala, Sri Lanka. Our research title is High Resolution Computed Tomography HRCT Chest Features of Symptomatic COVID-19 Patients in a Selected Population from Sri Lanka, an institution-based retrospective descriptive study. World Health Organization announced COVID-19 outbreak as a public health emergency of international concern in January 2020. They further declared it a pandemic in March 2020. There have been 4 outbreaks of COVID-19 infection in Sri Lanka up to September 2021, which was the outbreak with Delta variant. High-resolution computed tomography or HRCT test is used worldwide during follow-up of COVID-19 patients to aid the diagnosis, assess the severity, predict the clinical outcome, and to monitor the disease transformation. Despite the limited availability of CT in Sri Lanka, number of COVID patients undergoing HRCT tests have increased during the 4th outbreak. Current data on the common findings. Yet, there is no pathognomonic feature identified by HRCT test. However, they have identified some common findings. So, we used Zarifan et al. 2020 as our reference study, which was a meta-analysis done in 2020. According to that, the ground glass opacities was the most commonly reported HRCT test finding in COVID-19 patients, which was seen in 77% of patients. And the second, third, and fourth most common findings were reticulations, which was seen in 46%, air bronchogram, which was seen in 41%, and bronchial wall thickening, which was seen around 15%. The distribution was mainly bilateral, which was seen in 75%, and peripheral involvement was more common, which was seen around in 66%. However, there were no studies done in Sri Lanka to assess HRCT test features in COVID patients in our own population. So our objective was to describe the HRCT test features of symptomatic COVID-19 patients in a selected population in Sri Lanka. HRCT chest images of symptomatic and PCR positive COVID-19 patients were done retrospectively by 2 consultant radiologists. Whenever there was a disagreement, a third radiologist was involved. The study took from 1st of May 2021 to 15th of September 2021 at Navalok Hospital, Colombo. Statistical analysis was done using SPSS version. Study sample size was 118. All of them were PCR positive symptomatic patients. Median age was 54 years, ranging from 21 to 86 years, and the majority were males. So table 1 illustrates the age distribution. The majority were between 61 to 80 years age group. The most common finding was the ground glass opacities, similar to the international findings. In our population, it was reported in 75%. And second common finding in our population was bronchial dilatation, which was seen in 46%. And third common finding was enlarged blood vessels, seen in around 32%. However, mixed ground glass opacities with consolidations, crazy paving pattern, septal thickening, and air bronchogram were there as well. However, the rate of air bronchogram was low compared to that meta-analysis. Even the bronchial wall thickening and reticulations were reported in relatively lower rates compared to the international literature. Lobar collapse and lung cavitations and subpleural stripes were among the other findings. Also, some patients had pneumothorax, surgical emphysema, pleural effusion, mediastinal lymphadenopathy, and cardiomegaly. So, in summary, the ground glass opacities was the most common finding in both in the international literature as well as in our population. However, the reticulations, air bronchogram, and bronchial wall thickening was reported in relatively a lesser rate in our population compared to the international literature. However, bronchial dilatation and enlarged blood vessels were reported in relatively higher amounts in our population compared to the international studies. The exact reasons for these discrepancies is not yet understood. However, we have to illustrate that when we were doing the study, the Delta mutation was the most common COVID variant in Sri Lanka. And we only included symptomatic COVID patients within the first 21 days of illness to our study. Maybe those two factors affected the results. However, further studies are suggested to evaluate these changes. Maybe there is effect from the socio-demographic factors or anything else. The distribution in our population was mainly bilateral, similar to the international findings. So in 92% it was bilateral, in 5% it was unilateral, and in 2.5% of the patients, no lung involvement was seen in the CT findings. Majority had a diffuse involvement with a rate of 59%. Lower lobe predominance was seen in 28%, and upper lobe predominance was seen in 7%. Peripheral or the subpleural predominant involvement was seen in 75%. So even though there were some few discrepancies, the most common HRCT finding in both the international studies as well as in our study was the presence of ground glass opacity. In addition to that, in our study population, the bronchial dilatations and vessel enlargements were reported in significantly higher amounts. Similar to the international studies, the bilateral involvement was seen in majority of our population as well. So HRCT shows a range of changes, and it is very much useful in the diagnosis and evaluation of lung pathology in acute early phase of COVID-19. We like to acknowledge the Management Board and Research and Education Unit and all the staff members of Navalopital. Thank you very much.